Good morning, students. I'm Dr. Sri Ramya Devi, Assistant Professor from the Department of Dermatology. So today my topic is erythroderma. So what is erythroderma? Erythro means erythema, derma means skin. When there is redness in the skin, more than 90% along with scaling is known as erythroderma. It is first discovered by Von Hebra in 1868 and it is also known as exfoliative dermatitis. It does not represent any defined entity and clinical presentation of a variety of diseases. It comes under the pre-existing disease. Okay. So coming to epidemiology, incidence is 0.9 to 7.1 per 71 per 1 lakh outpatients. In males and female ratio 2:1 to 4:1. Age group is 41 to 61. Rare in children, it occurs in all races. So what is the etiology? When there is a pre-existing dermatosis, is the most common cause for adult. Adult erythroderma, the most common cause like psoriasis and eczema in children, drug-induced is the most common cause. What are the conditions causing erythroderma? So we will remember like its scalp. I means idiopathic. Another I for infections. In infections like herpes simplex virus, HIV infection, and dermatophytosis. Infestations like cluster scabies is the most common cause. Scalp. S stands for sarcoidosis. S another S for seborrheic dermatitis and C for contact dermatitis and collagen vascular diseases. A for atopic dermatitis and autoimmune conditions like SLE, pemphigus foliaceus, and paraneoplastic pemphigus lichen planus conditions. Lymphoma, leukemias, other carcinoma conditions, malignancy conditions that can lead to erythroderma, and P for psoriasis. This is a mnemonic to remember the causes of erythroderma, its scalp. So we'll see the elaborate conditions like eczema of various subtypes, psoriasis, lymphoma and leukemia, drugs, unknown etiology that is known as idiopathic, hereditary conditions like pityriasis rubra pilaris and ichthyosis, pemphigus foliaceus, other skin diseases like lichen planus, cluster scabies, dermatomyositis, and dermatophytosis. So diseases associated with erythroderma dermatosis like spongiotic dermatosis, conditions like atopic dermatitis, seborrheic dermatitis, contact dermatitis, stasis dermatitis, and in papillosquamous disorders like psoriasis, generalized pustular psoriasis, pityriasis rubra pilaris, and in bullous conditions like pemphigus foliaceus, paraneoplastic pemphigus, and bullous pemphigoid. So adverse drug reactions like maculopapular rash and breast syndromes, photosensitive condition like actinic dermatitis, others like pseudolymphoma, radiation recall dermatitis, erythema gyrata, repens. So systemic causes like dermatomyositis, subcutaneous lupus condition, acute graft versus host disease, post-operative transfusion induced thyrotoxicosis, sarcoidosis, hypercalcitonia, and calcemia, idiopathic hypereosinophilic syndrome. So infections I told like bacterial infections like tuberculosis, congenital syphilis, viral conditions like hepatitis C, HHV6 and HIV, fungal infections like dermatophyte histoplasmosis, congenital cutaneous candidiasis, parasite conditions like Norwegian scabies, toxoplasmosis, leishmaniasis, toxin-mediated infections like Staphylococcus standard skin syndrome and toxic shock syndrome. So malignancy, solid organ tumors like lung, prostate, thyroid, stomach, colon, rectum, fallopian tube, ovary carcinomas, lymphoproliferative cutaneous malignancies like T-cell lymphoma, Sézary syndrome, papilloerythroderma profugi, Hodgkin's lymphoma, Castleman disease, and acute myeloid leukemia and the chronic myeloid leukemia. Congenital conditions like immunodeficiencies, which include Viscount-Aldrich syndrome, SCID, Oman syndrome, Lenas syndrome, whereas metabolic condition like EFA deficiency, propionic acidemia, ichthyosis like bullous, non-bullous, Netherton syndrome, lamellar ichthyosis. What are the triggers for psoriatic erythroderma, which is the commonest cause in adult erythroderma? Medication, it includes lithium, terbinafine, antimalarials like quinine, chloroquine, systemic illness, discontinuation of potent topical or oral steroids, methotrexate, cyclosporin, biologics like ifalizumab, these are steroid-sparing agents, and irritant like using tar, infections like HIV infections, pregnancy, emotional stress, and phototherapy. Drugs causing erythroderma like antiepileptics, carbamazepine, phenytoin, phenobarbital, lamotrigine, antibiotics like penicillin, cephalosporins, and vancomycin, anti-malarials, isoniazid, dapsone, antihypertensives like thiazides, captopril, amiodarone, diltiazem, allopurinol, and NSAIDs is one of the cause. Quinidine, gold, lithium, sulfonylurea, omeprazole, and cimetidine. So, what is the pathogenesis of erythroderma? There will be increase in the level of expression of adhesion molecules like vascular cellular adhesion molecule and intercellular adhesion molecule. And these two molecules increases the epidermal proliferation, dermal inflammation, and release of cytokines. There will be an interaction between cytokines and adhesion molecules, which can result in the increase in the epidermal turnover rate. Normally, the epidermal turnover takes place about up to 72 days. Okay, the epidermal turnover is nothing but the cell takes time to travel from basal layer to reach the stratum corneum and exfoliate around 72 days. When the time period has been increased, scaling will be more. So what is the clinical features? There can be erythema, scaling, and pruritus. Okay, because of pruritus, chronic itching can lead to lichenification. These are three main clinical features. So other than that, you can constitutional features like fever, chills, rigor, and hypothermia or poikilothermia. So erythema can be localized and can spread to generalized within months. So scaling it takes after 2 to 6 days as fine scales or large sheets. In acute phase, that can be large and clustered scales. In chronic phase, smaller and drier scales will be there. Depending upon the scales, the characters of the scales, we can diagnose. Like fine scales in atopic dermatitis or dermatophytosis, brand like in seborrheic dermatitis, clustered in pemphigus foliaceus and crusted scabies. Exfoliative like scales are present in fluxes in drug reactions. Skin will be more bright, hot and dry. So in pruritus, around 90%, which are severe in malignancies like Sézary syndrome, intense itching will be there, which result in lichenification. Because of the edema and lichenification, skin tightening will be there. So a sign known as Pavitran's nose sign, where the condition is pad over the nose because of more sun exposure to this area, frequent rubbing of the nose, vascular insufficiency, anatomical shape and sebum. So there can be this pigmentation, mainly hyperpigmentation. There can also be hypo or depigmentation. Palmoplantar keratoderma, mainly in two disease you can see. In case of clustered scabies, there will be clustered along with thickening of palms. Palmoplantar keratoderma will be present. Whereas in case of Sézary syndrome, it can be more painful and fissured. Coming to the nail changes in erythroderma, nail changes present erythroderma in pre-existing dermatosis. There can be pits in psoriasis. In other cases, they develop subsequently. The nail changes are about 40%. The changes like thickening of the nail plate, views line, discoloration, brittleness, dullness, paronychia, and maybe shed, subungual hyperkeratosis, splinter hemorrhage, onycholysis, and alternating bands of nail plate discontinuity and leukonychia. So in eye changes, there can be two mainly ectropia, which is nothing but a inflammation edema of the lid, leads to eversion of the eyelid, and non-stop tearing will be there. Okay, that is known as epiphora. So in case of hair changes, there will be diffuse non-scarring alopecia. The chronic telogen effluvium will be there. Because of chronic scratching, it can result in lichenification. Is coming to lymph node. There can be slightly moderately enlargement and rubbery consistency. So dermatopathic lymphadenopathy or lipomyelinotic reticulosis, also known as Fortier Warringer disease. It's a type of paracortical hyperplasia is present in the lymph node when there is a chronic irritation. Okay. So it is commonly associated with the chronic erythroderma. Most commonly affects the axillary and inguinal lymph nodes, which are enlarged, firm, non-tender, mobile, which can be present with peripheral eosinophilia. In histology, it shows melanin and fat-laden reticular cells in the affected lymph nodes. So, what are the related physical findings? As I told previously, constitutional symptoms like tachycardia, high output cardiac failure. So, tachycardia is increase in heart rate. Okay. High output cardiac failure, thermoregulatory disturbances like poikilothermia, they will say. What is poikilothermia? Where there is an inability to regulate core body temperature with the external environmental temperature, which can be hypo or hypothermia. Anemia is present. Generalized lymphadenopathy, hepatomegaly mainly in drug-induced erythroderma, splenomegaly in malignancy conditions like lymphoma, and peripheral edema. Why there is peripheral edema? Because of congestive cardiac failure and increasing vascular permeability, there can be peripheral edema. So clinical features that can depends on underlying conditions like in eczematous dermatosis, exacerbation of existing lesion before generalization. Oozing is one of the main clinical features which are present in the eczema. Intense pruritus. Venous eczema most commonly in elderly people 6th to 7th decade, whereas in atopic dermatitis it occurs at any age. So in atopic dermatitis, you should ask history of localized disease, whether it is moderate to severe, personal or family history, and market pruritus. Classical sites like a fluxus, antecubital and popliteal fossa, because of the scratching, lichenification, prurito, nodularis like lesions are present. Excoriations, focal skin atrophy from years of using of potent topical steroids. So coming to psoriasis, you should ask history of localized disease, personal or family history of psoriasis, classical psoriasiform blocks on extensor aspect, whereas in atopic dermatitis, I told the site will be flexure aspect, whereas in psoriasis, extensor aspect is the most common site, like elbows, knees, and sacrum. After generalization, typical features of psoriatic plaques will be lost. There will be large lamellar sheets like scales, and there can be a psoriatic nail changes and psoriatic arthropathy. In pustular psoriasis, the pustules will be ruptured and forms a collarette of scaling. So coming to malignancy, the most common malignancy causing erythroderma like cutaneous T-cell lymphoma, more common than Hodgkin's lymphoma, then non-Hodgkin's lymphoma, leukemias, and myelodysplasia. There will be severe pruritus, universal erythroderma, painful fissure palmoplantar keratoderma, severe skin infiltration which result in leonine phases. What are the other conditions you know of leonine phases? One is a mastocytosis, other like LL, lepromatous leprosy. These kind of patients will have a leonine phases. Okay. Secondary lichenification and diffuse alopecia, eosinophilia, enlarged lymph nodes, and diffuse alopecia with hepatosplenomegaly is present in malignancies. What are the drugs? Recent start of a new drug or use of frequently implicated drug, rapid onset of rash and progression of erythroderma. Erythroderma from topical medication begins as dermatitis. Systemic medication begin as morbilliform or scarlatiform exanthem. So here you can see when there is a topical application of medication, you see here adverse reactions like dermatitis pattern which can evolve into erythroderma, whereas in case of oral drug induced adverse reactions result in scarletiniform or morbilliform rashes. Erythema appears first on flashes, then over whole skin. It can become generalized. Then there will be pruritus, facial edema, fever, lymphadenopathy, organomegaly, and it has good prognosis. Why it has good prognosis? We know the causative agent. So we are abruptly stopping the drug. When you stop the offending agent, the patient will recover within 6 weeks. So it has good prognosis. So erythroderma of unknown origin, also known as red man syndrome, also known as Hyphomie Roach, elderly male patients, long post-pleuritic erythroderma with partial and temporary remedial, and market palmoplantar keratoderma, market dermatopathic lymphadenopathy, which is a partial warringer disease, increased serum IgE level, commonest causes of idiopathic erythroderma like atopic eczema of elderly patients, intake of drugs, and pre-lymphomatous eruptions. So coming to other conditions like a pityriasis rubra pilaris. So it begins in childhood or adult life. Here you can see the lesions with the orange-red flower in large scales, follicular keratotic papules on elbows, knees, and back of fingers and toes. And here you should know about the Napus scleris orange, which is nothing but sparing of islands of normal scale. Okay, that is known as the Napus scleris. And orange discoloration of the skin and form and soles is presented. So like this, you can see in like a papilloerythroderma of OFG, there will be sparing of abdominal folds. Here in PRP, islands of sparing normal skin, which is known as the Napus scleris. So paraneoplastic erythroderma, most commonly associated with lymphoproliferative malignancies, including T-cell lymphoma, other than Sézary syndrome. The Sézary syndrome, what is the triad of Sézary syndrome? There will be Sézary cells, lymphadenopathy, and other thing is what? Erythroderma. So these three things will be present as a Sézary syndrome. Erythroderma occurs late with solid organ malignancies, which I described earlier. Fine scales and erythema accompanied by brownish hue. So here you can see a melanoerythroderma and cachexia. The patient will become lean. Okay, that is known as the cachexia due to muscle wasting. Next will be bullous dermatosis. Like pemphigus foliaceus, commonly present as erythroderma, impetigo like blisters and erosions will there. Initially, blisters will be there, which ruptures and leaves the erosions, and formation of collarette of scales and scale-like crusting will be present. Erythema is preceded by localized lesions on face and upper trunk. Erythrodermic forms of paraneoplastic pemphigus, which is associated with malignancies, and bullous pemphigoid are rare. So dermatophytosis are nothing but ring infection, like tinea infection, which is most commonly caused by Trichophyton rubrum. Here, the chronic infection with Trichophyton oleaceum is rarely causing the erythroderma. So, Norwegian scabies, which is an infestation. So, scabies, what is the key features or classical features of scabies? Three things will be there. One is nocturnal itching will be there, and burrows will be there. Then positive family history. What is a burrow? Define burrow. Burrow is a linear serpentine tunnel which is surmounted by papule and pustule excavated by the female mite. Okay. So what is the difference between classical and Norwegian scabies? So Classical, the mites will be around 12 mites only, whereas in Norwegian, it is also known as a crusted scabies, contains about millions of mites. Why there is a millions of mites? It most commonly affects the immunocompromised individuals, bedridden individuals who are hemiplegic individuals. Why it is increased? So there is a disturbance between the itch scratch cycle. When there is no itching, the scales won't fall apart. So it will accumulate and forms like a crusting. So in the crust, you can see the millions of mites. And heavily crusted hands and feet, thickened nails, as I told before you, burrows, similar history in family, and they can be associated with generalized erythema and scaling. Lichen planus, Erythroderma lichen planus is rare. Likened reaction to gold, quinone, and other drugs, erythroderma, initially there can be erythema and edema on subsiding, which results in the violaceous papules. So you tell me guys, why the sky is blue? Because of the sea reflection. Like that, here you can see the violaceous papules because of the Tyndall effect. Okay, here the patients will be not itching or scratching. They will do rubbing because scratching can give pain to the patient. So there will be typical lacy bluish white streaks in the buccal mucosa, which is known as the Wickham striae. So you should examine lichen planus patients the oral mucosa also. So in HIV infection, seroconversion following HIV infection, severe seborrheic dermatitis, and associated lymphoma due to antiretroviral therapy or ITT induced and due to unknown cause. Post-op erythroderma is a type of graft versus host disease following surgery along with blood transfusion, erythema, fever, pancytopenia, hepatic insufficiency. It can be fatal also. So I told there can be a sparing of abdominal fold like in condition like papilloerythroderma Fuji. Other thing I previously told, where there is a normal islands of normal skin, sparing of islands of normal skin, PRP, Pityriasis rubra pilaris, which is known as the napus flares. Likewise, in papilloerythroderma Fuji, the sparing of abdominal flushes, which is known as the Dekcharson. It is described by Fuji in 1984. That's why it's known as papilloerythroderma Fuji. Male are more common than females. In 8th and 7th decade is the most common decades. Clinical features like brownish red flat top papules that become confluent. Limbs and trunk are affected. Face and fluxes are spared, which can have intense pruritus. Lesion may develop among scratch marks, hyperkeratosis, and painful fissuring of palms and soles. There can be benign lymphadenopathy, circulating eosinophilia, serum Ig level has been increased, absolute or relative lymphocytopenia. So it can occur as a paraneoplastic phenomenon, occur in association with T cell and B cell lymphoma, gastric, lung, colon, prostate, and hepatocellular carcinoma. Can progress to mycosis fungoides. So consequences of erythroderma, like as I told previously, erythema edema will be there because of altered hemodynamics. Persistent inflammation of the skin leads to marked peripheral vasodilation. So increased blood flow and cardiac output results in high output cardiac failure. So altered thermoregulation, hypothermia, increased cutaneous blood flow, and heat loss can be through radiation or convection, leads to hypothermia, and which result in chills and rigor. Because of the hypothermia, there will be compensatory mechanisms against hypothermia. So because of that raised basal metabolic rate, make up for heat loss and shivering, attempt to raise core body temperature, failure to compensate result in poikilothermia. where failure to regulate core temperature equal to environmental temperature. So fever is due to interleukin 1 produced by damaged keratinocytes, hyperthermia due to intraepidermal occlusion of the sweat ducts, and also due to the secondary infection is the cause for fever. Whereas sudden onset hypothermia in relatively stabilized patient can result in septic shock. Sepsis is the one of the fatality condition in erythroderma and most common complication. So coming to the metabolic abnormalities, loss of body heat is compensated by increase in basal metabolic rate, pancreatitis, reduced insulin resistance and secretion, stress infection can lead to hyperglycemia with glycosuria. Tissue protein is used as energy source. Fluid and electrolyte imbalance. Usually, total body fat water loss is equal to around 400 ml per day. Transepidermal water loss is increased in erythroderma, which result in dehydration, decreased in urine output, hyperosmolar urine, pre-renal failure, and increase in serum creatinine and urea, blood urea, and low sodium and high potassium. Loss of nutrients. Main nutrients lost are protein and iron. Causes of hypoproteinemia like through scales, increased basal metabolic rate, reduced hepatic synthesis, dermatogenic enteropathy because of the protein malnutrition, reduced intake. Amount of protein lost via scales per day is 9 gram per meter square. Overall protein loss is 20 to 30 gram per meter square body surface area around per day. Maximum protein loss seen in psoriasis, then followed by drug reaction and eczema. So in oxidative skin lesions, combined protein loss through oozing from skin surface and urine 150 to 200 gram per day. Prominent muscle wasting will be there. In iron anemia due to iron and vitamin B12 deficiency loss through scale and impaired absorption is one of the cause for deficiency of iron and vitamin B12. Folate deficiency, increased cellular turnover rate, anemia of chronic disease, hemodilution underlying malignancies. So coming to peripheral edema, which is due to increased capillary leakage, hypoalbuminemia, because the proteins have been lost via the scales, which resulting in hypoalbuminemia, resulting in pedal edema. Associated heart failure, inflammation resulting from primary skin disease. And the proliferating and growth factors causes cytokines produced by damaged keratinocytes, induces dermal capillary proliferation and increase microvascular permeability. Pulmonary complications like pulmonary edema, acute respiratory distress syndrome, aspiration, pneumonitis. Infections like systemic entry of commensal, exogenous, endogenous microorganisms due to impaired barrier function. Long-term complications like in eye, ectropion. Ectropion is nothing but when there is an inflammation and edema in the eyelids, eversion of the eyelids. Epiphora, like non-stop tearing is known as epiphora. Entropion, skin-like pigmentary changes, most commonly hyperpigmentation. Hair like a chronic tenogen effluvium. Nail like a bucine, distal onycholysis, dystrophy, total shedding of nails and nail. Murray-Williams-Watt or eruptive acanthoma following resolution of erythroderma. What are the investigations you do in this case? First, you should do a master health checkup like investigations, complete blood count with ESR, RFT, that is renal function test, liver function test, sugar or random blood sugar test, a serum electrolyte test, urine test. So everything you should do. Anemia. So from that you can rule out anemia, leukocytosis, lymphocytosis, eosinophilia, which is most commonly associated with malignancies, increased IgE, elevated ESR, decreased serum albumin level, increased serum creatinine and blood urea, hyponatremia, hyperkalemia, hypocalcemia, and proteinuria. So in peripheral smear, we can say eosinophils, atypical lymphocytes, Sézary cells to rule out lymphomas and leukemias, chest X-ray to rule out underlying malignancies and complications like pneumonia, which is the most common cause for fatality, and USG abdomen. So elevated Ig levels seen in 81% of psoriatic erythroderma cases and eosinophilia seen in 20% of erythroderma cases, where high eosinophil count is seen in Hodgkin's disease should also be ruled out. Erythrodermic CTCL shows atypical mononuclear cells, that is known as Sézary cells, comprising more than 20% of total lymphocyte count. Demonstration of clonal T cell receptor gene rearrangement, which is sensitive and specific test. Less than 10% of Sézary cells present in psoriasis, atopic dermatitis, discoid lupus, and lichen planus and parapsoriasis. Coming to histopathology, histopathological features of underlying diseases are present in 50% of patients. Multiple skin punch biopsies plus the clinical evaluation resulting in diagnosis. Histological features vary depending on stage and severity of inflammation. Histologic clues like in acute, there can be spongiosis, parakeratosis, or prominent non-specific inflammatory infiltrate in edematous dermis. Chronic condition shows acanthosis, nothing but increase in the thickness of stratum corneum or epidermis, and elongation of reticulus. In psoriasis, there can be parakeratosis, collection of neutrophil in stratum corneum and stratum spinosus, Munro microabscess, they called as a Munro microabscess, hypogranulosis, granular layer will be thinned out, regular acanthosis, broadening and the fusion of reticulus, elongation of reticulus will be present, which appear as a camel foot appearance, dilated tortuous papillary blood vessels. In drug-induced, there can be interface dermatitis, vacuolar degeneration, necrotic keratinocytes at all levels of epidermis, perivascular and interface inflammation with eosinophils. Idiopathic, non-specific, usually subacute or chronic spongiortic dermatitis like changes, and cutaneous T-cell lymphoma or Sézary band-like infiltrate in papillary dermis containing small to medium-sized mononuclear cells with hyperchromatic cerebriform nuclei and small inflammatory cells. Atypical mononuclear cells singly and linearly in basal cell layer. Intraepidermal nest of atypical cells present in portrait microabscesses, which are absent or minimal spongiosis will be present, often lichen infiltrate. Special tests like immunophenotyping to detect clonal T cell population in skin and blood. In pemphigoid, subepidermal bulla, dermal eosinophilic spongiosis will be present. Special tests like BIF is done. Direct immunofluorescence can be done. In pemphigus, intraepidermal bulla, acantholysis, and the loss of coherence between the epidermal cells is known as acantholysis, and the pemphigus is one of the cause. Eosinophilic or neutrophilic spongiosis present. Specific tests like direct immunofluorescence can be done. So in pityriasis rubra pilaris, foci of orthokeratosis, alternating with parakeratosis in both vertical and horizontal directions. Slight psoriasiform hyperplasia may be seen but with an intact granular layer. Superficial and sparse interstitial infiltrates of lymphocytes. Neutrophils are absent. So in management, pillars in the management like nursing care, monitoring the hemodynamic changes, fluid electrolyte balance and nutrition, prevention of complication, prompt identification of the risk factors, and topical therapy. For that, we should put a pulse, temperature, and BP chart along with input-output. So in nursing care and general guidelines, admit the patient and manage in specialized ward, maintain an environmental temperature at 30 to 32 degrees Celsius, regular cleaning and removal of crust, once or twice daily bathing in lukewarm water, which the temperature should be 35 to 38. IV line should be secured. Urinary catheter or condom catheter can be applied. Daily input or output chart, record body temperature, fourth hourly record of BP, pulse rate, urine volume, osmotic, which I mentioned previously. So monitoring hemodynamic changes, indicators of hemodynamic status, pulse rate, urine output and urine osmolality, urine output of 50 to 100 ml per hour, adequate tissue perfusion, urine osmolality less than 1020. Blood pressure not a good indicator of fluid status of body. So reduction in urine volume resulting in hypovolemia or septicemia, pulse rate more than 120 per minute means negative fluid balance. Fluid electrolyte and nutrition. Initial fluid choice will be colloids like human albumin and normal saline. Daily fluid requirement has to be calculated depending on previous day's output. Combination of IV and enteral supplementation can be given. High protein diet like 2 to 3 gram per kg body weight per day in adult and 3 to 4 gram per kg body weight per day in children. As you know, 200 gram protein is lost per day in erythroderma, mainly in psoriasis, followed by drug reaction and eczema. So prevention of sepsis like regular hand washing and aseptic handling of the patient, bacteriology of the skin lesion performed initially like sending blood culture, pus culture if there is any using and on alternate days. Altered sensorium in the form of anxiety or confusion is the first sign of sepsis. Increased respiratory rate is the first sign of hypoxia resulting from pneumonia. And that the prophylactic use of antibiotic in the absence of evident infection is not agreeable. Which are the definite indications of antibiotic use? High bacterial count in single strain from skin or catheter sample of urine, sudden hypothermia in a relatively stabilized patient, confused mental status, anxiety and excitement, symptoms of infection pertaining to a particular system, example pneumonia or UTI, urinary tract infection. Topical therapy like we are giving commonly liquid paraffin, non-physiologic lipids, petrolatum jelly, lanolin in vapor permeable dressings or barrier repair agents, dressings with gauze pieces, whereas in physiologic lipids, component mixture of cholesterol, ceramide, and free fatty acids in an optimized ratio of 3:1:1 accelerates the barrier repair. So biological dresses like amnion and collagen-based skin substitutes, banana leaves like we treat like a fire accident patients, we apply a banana leaf stalk. Over the banana leaves, we apply liquid paraffin and ask the patient to lay down it because the skin is more damaged. 90% of skin is involved. So when they lie down in the normal bed, the skins will be peeled off. Okay, so we should avoid the friction. We are asking the patient to the liquid paraffin applied banana leaves in their beds. Cadaveric allografts, cultured human allogenic or autologous epidermal sheets, and human newborn fibroblast cultured on a nylon mesh of biofilm or newer skin covering substitutes. Others like sedatives like diazepam, anticoagulants, H2 blockers to prevent stress ulcers, hyperglycemia. Insulin can be given to control of hyperglycemia. Ophthalmic care like protective ocular pads, periodic installation of normal saline or artificial tears can be given. Use of gas like permeable scleral contact lenses and amniotic membrane has been successfully used for dressing eye lesions in patients with 10. Toxic epidermal necrolysis, which occurs due to the drug reaction. Management of underlying conditions. Avoid the drug in drug-induced methotrexate in psoriatic erythroderma. So in psoriasis means we can start methotrexate, which is a steroid-sparing agent, is a drug of choice in psoriasis. Other than methotrexate, we can use cyclosporine. These two drugs are the drug of choice for psoriatic erythroderma. Systemic steroid is the drug of choice for drug hypersensitivity syndrome and patient follow-up for sequelae. Poor prognostic factors. Which condition I told good prognostic factor? Drug induced. Okay, we know the cause, which drug is offending agent. We stop the drug and within 6 weeks the patient recovers. What are the poor prognostic factors like in older age group, larger body surface area involvement, presence of severe neutropenia, early thrombocytopenia, high blood urea nitrogen level, a causative drug with long half-life in drug-induced cases. Prognosis and clinical course fatal in very young and elderly patient, high mortality due to severe drug reactions, lymphoproliferative malignancies, and pemphigus foliaceous and idiopathic erythroderma. Cause of death mainly due to sepsis, pneumonia, and cardiac failure. Drug-induced erythroderma due to rapid course and recover completely and discontinuation of the drug. There can be a good prognosis. Psoriatic or atopic erythroderma improvement takes weeks to months. Thank you.